Yeah. Should we start the session?
Yeah, sure.
Yeah, I think Madam is the first speaker, I think.
Yes.
Yeah. So I'll share my screen.
First of all, invite everyone to this session on dioptric distress. And our first speaker is Dr. Chitra Ramamurthy. She, of course, any introduction, every ophthalmologist in India and internationally know her very well. However, she is the chairman ARC AIOS and director of Eye Foundation group of hospitals. She has taken ARC and AIOS to a different level in her tenure. And over to you, ma'am, for your first talk.
Okay. Now you can see my screen, all of you?
Yes, yes.
So the topic which I'm going to be dealing in the next few minutes is, why is cataract surgery today poised to be a refractive cataract surgery? It's essentially because we understand that it's what's best for the patients. And today we are poised with the best in biometry, the formulas, the IOLs of the different designs, and the surgical techniques is at its zenith. But it's also important that we start looking at all these essentials which are critical when you're evaluating these patients. Like, we need to know whether we are going to address the asphericity of this eye, or whether we are going to give multifocality or an extended range of vision, or we are going to combine it with toricity, and then goes in our action plan. So I'm going to divide this talk in different pearls. So the pearl one is, what is the right time? The right time is probably when you're sort of quite confident about your surgical skills, and you're getting consistent operative outcomes, and you know that you're just there with a target emmetropia in many of your cases. Going forward, it is also about your team. You could have brought a thought into it, but it has to get integrated into all your staff. So right from the front desk to your room sister should be talking the same language. Pearl 2 is looking at the workflow and the presenting options. Now, what we mean by that is how to pick your patients most wisely. We do need to tell them, when you want your premium lenses, that we could do away with much of the fear which was there with the earlier multifocal or presbyopia correcting lenses. And today, with some amount of neural adaptation and with realistic expectations, you can go forward. But that doesn't mean that you crowd your patients with enormous amount of information about all possible lenses. Rather, it makes sense to individualize or tailor make it to a particular patient as to what that patient needs. In fact, in our setup, what we actually do is, what we do is actually, before even a contact tonometry is done, once the patient shows interest in undergoing a cataract surgery, we first do a biometry, try to understand whether there is some amount of toricity also involved, and then take forward our discussion with the particular patient so that we are more specific to guide the patient about his Iol Power selection. And then the pearl number 3 is the precise biometry. I do know, all of us know, that the immersion biometers are doing good. So are the different biometries, optical biometries, which have come in based on different principles. Essentially, there are small changes which happen with the optical biometer, is that the frequency of the laser beam is very significantly high, and it's able to identify the exact fixation point precisely on the fovea, and the actual difference between an immersion and the optical biometer is just about 200 micron. So, but having said that, there are many of us are using immersion biometry. So what attention to detail is needed is, you should need to check whether all those spikes on the cornea, the lens, the retina, everything should be of nearly equal amplitude, and you keep your gain at the lowest level at which you're getting these equal spikes. You should also ensure that you have the scleral spikes, which ensure that the probe is well centered on the eye. You should take a number of readings. You should not compress the eyeball, and your standard deviation should be less than 0.06. When you're doing measuring two eyes, when you're doing a surgery in one eye, it's important that you look at the other eye, even if it's a pseudophakic eye, because if there is a gross difference in axial length, it should warn you that there's an asymmetry. Could it be an amblyopia which is being looked or not looked into? All of these factors should be kept in mind. It is also important that we are sort of tuned that if the axial length difference is more than 0.3, if the K value between the two eyes is more than 1, and if the IOL power is more than 1 diopter, probably we need to recheck our measurements. Now, looking at this particular example, the patient had a K value in the right eye in 38.5 and the other eye, it was 43. So what we realize is that the right eye is flatter. Now, if you had not noticed it, you would have not taken the second leading question with your patient, because a patient often may not reveal the information. And this patient had undergone a laser refractive surgery 30 years back. So then it becomes necessary, we use the right formulae, you go on the LVC mode, and then you realize that the Iol Power calculation was actually different from what it could have been otherwise. It is very important for us to look at the quality of the raw data. What you understand by this is, this was a particular patient who showed the astigmatism of +2 or more diopters. But we looked at the eye, a closer view, we realized there were a lot of dry eye symptoms, pigment epithelial defects. So we had to start this patient first on treatment of the dry eye, and then a repeat keratometry, Iol Power calculation actually showed that the amount of astigmatism was only 0.2. Imagine the amount of difference in the final Iol Power which you would have implanted in the eye if you had not looked into the fact that this patient had dry eye which needed to be treated. Look, talking about dry eye, even if you look at the LED points on the Iol Master, those fishtail appearance of those spots, if you look at the Placido Myers, if they are not very regular, these are some indicators. In fact, if you have your technician, you should ensure that he's the same standard technician who's doing consistently for all your patients, or 2 or more or 3 of them as your practice expands. Certain important points which needs to be looked into. His signal to noise ratio should be more than 2. The standard deviation should be less than 0.2 or 30 micron difference. These are some very critical points which needs to be ensured. And also you should look at those LED points, whether they are distinct and clear. And this would allow you to understand whether the measurements have been taken properly. But having said that, if the astigmatic difference is more than 3 to 3.5 diopters, if the difference in the Iol power between the two eyes or the ACT depth between the two eyes is different, we need to go back and do a remeasurement before we take that as a final value. In fact, keratometry, it makes sense for us to do it in 2 or more instruments because each of them are measuring at a different point. The manual K is at 3.2 ring, the Iol Master measures in 3 rings, the Lens Master in 2 rings. And what we need to remember is how close to you center you measure, more accurate you are. And in fact, if there is a comparison between 2 modalities, it sometimes brings out a fact that there is some discrepancy in the error. Then you look at the corneal surface with greater clarity and understand that that surface issue has to be addressed. If you have access to the Iol Master 700, you have the ability to do a total keratometry wherein it uses a toric model to measure the anterior cornea and the posterior cornea with the help of the swept OCT, and it interpolates the information from the posterior cornea and gives you a total keratometric value, which can be incorporated into your barrel universal 2 and barrel toric and go on to TK toric and 2K universal, and you can even use it into your post-LASIK measurement eyes. But you need to remember that there are many other formulas which already have the mathematical model to calculate the posterior corneal astigmatism. And if you add up both of these, you might end up overcorrecting these eyes. Actually, much of this discussion do not have a role play in 70% of the eyes which are so straightforward. It's only in these 30% of the eyes, if they have a dry eye issues, you need to go back and look and retake the measurements. If there is some suspicion of an asymmetric astigmatism or irregularity on the corneal surface, you need to do a tomography, and then you need to ensure that the toric measurements are also incorporated if the patient wants a toric IOL. The choice of formula is your fourth point. Now here we have to keep in mind that as we go on to the 4th generation formulas, there are a lot more variables which are incorporated, which is actually the need of the hour, because how close you are into measuring the effective lens position of the IOL in the eye, that would bring in greater accuracy in your addressing the target emmetropia. In fact, with the Barrett's, you're able to even measure the lens factor, which is the distance between the posterior surface of the eye to the principal plane of the IOL. And these factors would bring in greater accuracy. It goes one step further, and it also measures the effective lens position varying with the different geometry of the eyes. Like you could be having a biconvex lens and with the higher powers go on to plano-convex and meniscus lens, and the ELP would change with the geometry of the IOLs, and these are calculated. In fact, we did a study comparing the Barrett Universal 2 with the third generation formula in some n number of eyes. And what we found was consistently the Barrett formula was getting within plus minus 0.5 in the normal and in the long eyes, that is over 90% of the times. So it makes sense to go in for the later generation formulas to bring in that amount of precision when you're doing a refractive cataract surgery, rather something which mandates in every single patient of ours. Pearl number 5 is looking into your toric calculator. Like we need to know whether your toric calculator is going to factor in the posterior corneal astigmatism, the toricity ratio, and the centroid SIA. Now, we all know that the posterior cornea is against the rule in 90% of the cases. And with this, when added up with the rule cornea, the total corneal astigmatism would actually reduce. It would become more if both the anterior and posterior cornea are against the rule. Again, if you look at ELP and the toricity ratio, how it's going to vary, like it might be going a rapid run through, but if it is an average IOL power of 22 diopters and your ELP is 5.5, then your toricity ratio is 1.45. That is in an average eye. But if your IOL power is 10 and your ELP is 6.5, the toricity ratio is 1.7. And if your IOL power is 46 and your ELP is 4, it is 1.1. Imagine a difference from 1.1 to 1.74 can occur with the changes of IOL power and the ELP. And these can bring in errors. You can't use a standard toricity ratio of 1.45, and your toric calculators should have brought in a way to measure the toricity ratio in different axial lengths. It is also important for us to remember that we can do away with the surgical induced astigmatism. Rather, if you look at the centroid value, any incision of 2.4 or less, the centroid value is less than 0.1, then that is all that needs to be factored in. Now, supposing you're using an immersion biometer, you can take all your measurements on the immersion biometer, your keratometry, your axial length, the AC depth, and you could add the acoustic factor of the particular IOL which you want to implant and feed it online into the Barrett IOL calculator, and it would tell you what should be your IOL power and what should be the axis of placement, and even inform you what would be the residual expected. Now, the Pearl number 6 tells you about the threshold of the IOL power. Now, if you have a 0.97 with the rule, it actually tells you that don't have to use a toric. Whereas if the astigmatism is even lesser, 0.84, it tells you that you need to use an IOL, toric IOL power in the T3 series. So it depends what you're treating, a with the rule or the against the rule examination, astigmatism. Now, Pearl 7, of course, goes back to tell you repeatedly that you need to do an ideal IOP pre-op evaluation right from the ocular surface, the refraction, to your biometry, and right up to the retina. You need to look at the cornea. And if you suspect some kind of a Fuchs endothelial dystrophy, you might have to tell the patient that there is a possibility of a decompensation later, that you might have to do a DSEK in these eyes. It's important for you to do a topography to see whether the astigmatism is a regular astigmatism, an orthogonal, or is there an irregularity. You need to do the OCT macula to know whether there is macula is healthy, whether there's an epiretinal membrane or a lamellar hole. You need to do an eye trace when you're doing these premium IOLs, if you could, to find out what is the angle alpha, whether it's less than 0.5, what is the higher order aberrations. We need to know that the angle alpha is the angulation between the optic line passing through the optical center and the visual axis. And if this angle is more than 0.5, you would probably veer off implanting a multifocal IOL in these eyes. But what we now understand is with the modern multifocal and extended range or trifocals, the central zone has been increased. So this allows a tolerance of having an angle alpha of even 0.8 and still not have any of these visual disturbances. Now, Pearl number 8 tells you to match the technology to the patient. You have IOL designs with different optical principles and different focality concepts. You have lenses which will give you far, near, but also improve your distant vision without increasing your dysphotopsia. So it becomes necessary now to understand what is defocus curve, because a defocus curve is the best objective indicator of what is the IOL performance. Like taking you through this example, with the patient corrected for full distant vision, it gives you a clear vision, and then you keep adding plus 0.5 onto this lens frame, and you keep seeing till when the patient is able to see, and that gives you the range of vision with that multifocal IOL or a trifocal is going to allow. Like in this particular example, it tells you that your bifocal lens is going to give you a range of vision up to 50 or 42 or 33, whether it is going to give you an extended range of vision. So essentially, you could titrate your choice of these premium IOLs based on the requirement of these patients. Of course, it goes without saying that it has to be a perfect biometry. And if you have access to an LRCS platform, you could ensure that you could center it on the capsular bag, which is the way to go. You could ensure that you have the right number of fragments, which is necessary for the density of the lens and the softening. You invariably get a free floating rhexis. You just have to bunch it up and lift it and remove it. A gentle hydro is enough, because in these eyes, there's some amount of pneumodissection is done. And you do not have to use an ultrasound power in the separation, the chopping, because all you need to is to just prise these fragments apart by just gripping them, go hold of them with just that punch of longitudinal phaco, and then go on to emulsify this cataract and then place a lens most optimally. Pearl number 10 tells us that our threshold of correcting astigmatism becomes very low when you're using a multifocal lens. This patient had a plus 0.8 or 1 diopter of astigmatism, and we just went ahead and did a pan-optics IOL, and the patient ended up with a small amount of astigmatism and had to be promised a laser vision correction at a later date. We got to be more intelligent and did a pan-optic toric in the other eye, and then went ahead and did a laser vision touch-up in the first eye, and ended up with a plano power in both eyes. The other important point is, if you have a very low diopter of astigmatism, you have access to the femtocataract platform, go ahead and do the arcuates, because today the way you can measure the depth, we have the best of formula, you have the pachymetry information, you have the OCT information, you have the topography, and you could precisely mark your arcuates so that that amount of debulking of astigmatism is done and the patient does optimally well. Now, nailing the target axis is also critical. If you have access to the slit lamp, you could use that beam to run across the pupillary area, and you can mark your 3 o'clock, 6 o'clock. You can use your Asico bubble marker to mark your 3 o'clock, 9 o'clock, and 6 o'clock. You should ensure that those spots are placed in a dry eye. There is no smudging which is happening. Even if you do not have access to the Varion or other overlay devices, you could use a Mendelssohn's marker. And what you could do is place it on the eye and mark where is the your 3 o'clock, 6 o'clock. You redefine it, which has already been marked downstairs in yours over your slit lamp, and use your toric IOL marker and mark it, and go ahead with performing a surgery. Of course, the surgery, all of us I don't have to go into the details. You do a good cataract surgery, but what it helps is it gives you an overlay. So after doing a good bicompartment viscoelastic removal, you could just align it along the toric axis and lock it into that position after removal of the entire viscoelastic. Now, what comes if the toric IOL is not in axis? That is the next pearl. You need to check where it is presently placed, what it should have been placed. Then you feed all this information with the current refraction in the astigmaticfix.com. It will tell you how much of rotation is needed. But for this, you need to look into the refraction. The spherical equivalent has to be near zero, as it is in this particular case. And if the spherical equivalent is zero, then it makes sense to rotate, because otherwise the problem is lying in the IOL. So you could need to do a bioptics to correct that residual, or you could do an IOL exchange. And today, with the help of the Barrett RX formula, it will tell you whether you have to rotate these eyes, whether you need to place a piggyback IOL, or whether you need to do a toric exchange. So how long would I wait before I realign my lens is the next question. And it probably makes sense to wait for a couple of weeks till the capsule rhexis shrinks a little and the IOL is more stably placed, and then you could do it. And the pearl number 14 is how do you follow up? There could be still unhappy patients with all of which you have done this far. Then you need to understand whether the ocular surface is dry, whether there is some amount of residual astigmatism, whether there is PCO, and you would address the PCO only if you're sure you're not going to do an IOL exchange. Is there something there in the retina which is all need to be addressed? Is your IOL centered? Is there a small amount of dialysis which was missed? Do you need to place a CTR? And finally, you have to also remember that you could have done a good surgery. It could just have been a wrong patient. And probably you should tell all these patients that the laser vision correction may be just a part of plan. A touch-up may be needed because these implants, all of them come in a certain size. And the last pearl is the top concern. Let us understand, I've read out all those pearls to you, but we are not selling a product across to a patient. We are actually educating a patient. And what becomes necessary for us to move on to the next step of making a cataract surgery, a refractive cataract surgery, is to have a very conceptualized approach in our mind, open our minds to all possible challenges so that you just take the right path and get that target emmetropia which you have been looking at. Thank you very much.
Thank you, ma'am. That was a wonderful presentation and a huge task of putting everything together. Thank you so much. And you wonderfully reiterated how dry eye can cause so many problems with IOL calculation and how important it is to get the right IOL power. Ma'am, one question I would like to ask you, that when we are doing any, whether it is optical biometry or ultrasound, how do we know that we have actually targeted the macula?
No, in optical biometry, the fixation check is done. So that is not your challenge. The challenge with immersion biometry comes more in those eyes, especially which are very high myopes, wherein it actually measures the anatomical axial length and not the refractive axial length, which is measured by the optical biometers. So therein comes error. Largely, the immersion could do very well if you take care of those essential points in your measurements. However, having said it all, that we have to use the best of the formulae too, and it's just not the accuracy in biometry measurements alone, and a consistency in our surgical performance also. Everything actually adds up to ensure that you have a target emmetropia. That's why my first few slides said that we need to also tell our patients to have realistic expectations.
Yes. Thank you, ma'am. Are there any other questions? Or do we take the questions last? I think
I might have to go for
yes, I thought as much. That's why anybody with any questions could ask ma'am right now. Thank you, ma'am, for the wonderful presentation. Thank you so much.
Thank you very much. Thank
it
you.
is a joy to
thanks
listen
a lot to COSCON and all its members for giving me this wonderful opportunity, because I truly believe that it's a huge, huge favor to come and talk in this very prestigious session. Thank you very much.
Thank you so much, ma'am. Now, on to the next speaker. Dr. Mohammad Shahbaz. He is a cornea and cataract and refractive surgeon from Eye Foundation, Bangalore. And he's going to talk to us about ultrasound biometry the right way, choosing the right machine, right method, and right metrics, example based. Over to you, Dr. Shahbaz.
Nice introduction. Good morning, everyone. I will be talking on USP biometry, the right way, choosing the right machines. I'm Dr. Mohammad Shahbaz from Eye Foundation Hospital, Bangalore. I'd like to thank Dr. Iol Kumar for including me in his course. Biometry can be divided into three components needed to calculate Iol power: axial length, corneal power, and effective lens position. Sir Horad Ledley implanted the first Iol in cataract surgery, post-operative refractive survival 20 diagnosis. And we all know these are the results of the cataract surgery to be emmetropia. This is how the importance of axial length comes. Axial length is Y plus effective lens position or estimated lens position. ELP is defined as the distance from the anterior surface vertex of the cornea to the effective principal plane of the IOL in the visual axis. And Y is the distance from the principal plane of IOL to the photoreceptors in the visual axis. The error of axial length is very significant. 1 millimeter change will cause 2.5 diopter change in IOL. The error drops to 1.75 diopter per millimeter in very long eyes, and it jumps to 3.75 millimeter diopter per millimeter in very short eye. Greater care should be taken in measuring short eye, and always measure axial in both the eyes. Ultrasound, application, and immersion, and the optical. These are the method of a measurement of axial length. I will be concentrating on ultrasound method, that is application and immersion. In ultrasound method, transducer is used to send ultrasound pulse, usually 8 to 10 megahertz, to create a sound beam which passes through the eye. Sound beam is reflected back at the interface of changing tissue density, like anterior or posterior lens capsule. These echoes are displayed as vertical spikes rising from a baseline. The time taken for the sound wave to return back is converted into distance using the velocity of sound through the Heges tissue. Now, this is the velocity of sound through the Heges tissue. Why it is important? If you have a PMM IOL, the velocity will be very high, while if you have silicon IOL or silicon field wire, the velocity is very low. Hofer calculated average sound speed meter per second for various conditions of a 23.5 millimeter eye. And he has given the chart we can apply during the measurement. Application method is a contact method where probe touches the cornea. After instilling local anesthetic drops, ask the patient to fix at a target straight ahead. Probe is brought forward to touch the corneal apex, ensuring no pressure to prevent corneal compression. This is the schematic diagram, and you can see the probe is just touching the cornea. It is not pressing, and the beam is going and it is coming back, and every tissue interface it is giving a strength. And this is the photographic presentation of the same. In this video, I'm just to go about and do the application. This is instilling of anesthetic eye drop. Patient head should be in proper position, and you have to ask the patient to look straight at a fixation target, and then open the eyes, make the head straight, bring the probe, stabilize the probe with the other hand, and just touch the apex of the cornea. And once it is aligned properly, the machine will automatically start taking the reading. This is the automatic mode. In Control, it takes 10 to 15 reading, and then it gives the best one, and you that. Manual mode, examiner can manually select the scan with the appropriate spike and then freeze the scan to get the measurement. May be preferred in aphakic and pseudophakic eyes when the spikes are difficult to obtain. While automatic mode, the machine automatically selects the scan of good quality, like we have seen in this video. Normal scan has 4 spikes, first from the cornea, anterior lens capsule, posterior lens capsule, and retina. The axial length from the corneal spike to the retinal spike. Axial length is from the corneal spike to the retinal spike. The sensitivity may need to be increased in dense cataract. At least 3 consistent high quality reading should be taken. Always measure both eyes. The difference of 0.3 millimeter between both eyes should prompt re-examination and clinical and refractive correlation. If the beam does not pass through the center of the lens, the posterior spike will be shorter, and you have to adjust that. Absence of scleral spike and spike from the orbital fat means that the beam is not aligned with the macula, it is aligned with the optic nerve. So you have to move your probe slightly temporally. In aphakic eye, select aphakic mode. Use medium to high sensitivity. Use manual mode, as absence of lens spike can easily lead to misalignment of probe away from the macula. If difficult, align first along the optic nerve, then tilt the probe temporarily till scleral and orbital spikes starts appearing. In pseudophakic mode, use pseudophakic mode. If this mode is not available, use cataractus mode and set the velocity appropriately. Use manual mode, obtain high spike from IOL followed by multiple reduplication equals. Advantage of operation method. It's easy to learn, quicker to perform, and no additional space is required to make the patient supine or recline. These are the various machines. All are good. Anyone you can use. In this video, I have used Contel. Then coming to the immersion method, patient is placed supine in a reclining examination chair. Local anesthetic is instilled. A scleral shell is placed between the lids. It can be Henschen's, Prager's, or Korn cells. The scleral shell is filled with a solution. Avoid air bubble, which cause dampening of the speed of sound. Prager or Korn cells have a tight fit. Hence, BSS may be used as a coupling fluid. These are various types of cells. You can see there's a Korn, Oceans, and Prager cells. The ultrasound probe is immersed in the solution, keeping it 5 to 10 mm away from the cornea. And the next, you can see the immersion method. The probe dips into the ocean cells. The ultrasound probe is inserted into the shell, keeping the tip 5 to 10 meters away from the cornea. Ask the patient to look with the fellow eye at a fixation point or at a ceiling. In a one-eyed patient, you can use proprioceptive feedback like thumb or fist. Gently move the probe until it is properly aligned with the optical axis of the eye and an acceptable A scan echo is obtained. This is how you do in case of reclining chair, and this video shows is to anesthetize the eye, put a Tarakan eye drop, make the head straight, and then place the cell inside the eye. Ask the patient to fix as a fixation point. And after placing the shell, fill it with the BSS solution. And slight adjust the probe. Once the probe is aligned, the machine will start taking the reading in automated mode. And it takes, this Contel takes almost 10 to 15 reading and gives you the best one. So this is the scan obtained in immersion method. Ultrasound display, the first beam if you are seeing is then the corneal anterior surface and posterior corneal surface, then the anterior lens capsule and posterior lens capsule, then the retina and sclera, and then orbital fan. The advantage of immersion method is no applanation or compression of the cornea, which shortens the eyeball by 0.2 millimeter on an average. Many studies have shown that. The objective alignment of ultrasonic beam with the optical axis of the eye is more reliable than the subjective alignment using the fixation target. Easier alignment due to separate corneal spikes, and optimal results comparable to the optical method. This is very important. You should always sterilize the shells before using it. The thorough soaking of the shells and probe in a beaker of alcohol or hydrogen peroxide for at least 5 minutes prior to use. Allow the immersion cell to dry completely or flush with BSS, as alcohol may remove the corneal epithelial cells. Remeasurement of both eye if the difference between the two eyes is more than 3 millimeter, if the axial length is smaller than 22 millimeter or it is larger than 25 millimeters, and if the axial length does not correlate with the spectacle refraction. The source of error, axial length too short in cases if you have compressed the eye, if there is vitreous opacity, RD, thickening of RCS, improper velocity setting. And axial length become too long if the fluid bridge between the probe and the cornea wipe out the excessive tear, avoid using gonioscopic solution. Improper velocity setting can also lead to high as well as low axial length. Measuring a scleral spike instead of retinal spike can cause high axial length. Thanks.
Thank you, Dr. Mohammad Shahbaz. That was a wonderful presentation on ultrasound biometry and how it gives us very good results if we see the graphs properly. I would like to ask you, normally it is said that when we do a biometry, it should be like a completely version eye, like no drops should have been put, like dilating drops should not be put before a biometry. Does it make a difference in an ultrasound biometer?
In ultrasound biometer, it will not make much difference, ma'am, because we are asking the patient to fix at the target point. And this is the, like if you compare with optical, it's definitely much advanced and it focuses directly with the macula. While in ultrasound, we are not very sure, but most of the time it comes correct. But in this ultrasound, you cannot make it sure that it is going exactly on the macula or not. That's why all those cases of like posterior cephaloma and other conditions, definitely the optical biometer will be much better.
Yes, and also I guess in very mature and hypermature cataracts, where your routine optical biometers, they cannot penetrate. Here, the ultrasound biometers definitely score over the optical.
Yeah, the immersions has quite good results. Like it is quite comparable to optical. And in all those cases, with density is more wide cataracts, we use immersion in those cases.
And
mostly the application is outdated now. Most of us are not doing application except like if you don't have the option of immersion. So because that goes, it is not very consistent. Application is not inconsistent. It's the same 3 to 4 times. If you do, it will come different readings make up. Because you cannot, like your hand cannot be very much raised. Though we try to do that, but still, while in immersion, you don't have this issue because it is quite away from the corner.
Yes. Another question I had was, when we repeat the biometry and we find that the readings are very different, like your axial length readings are different from the first time that you did it. What do you do? Do you choose the first one or the second one? What do you do?
See, if two readings are not then we have to repeat again. And we have to see like, and then we have to correlate. That's what we can correlate with the refractive correction of the patient also. That's also very important. If it is coming, these things happen if it is very high or very low. In that only normal cases, it doesn't happen. Maybe minor differences may be there, like including the retinal thickness and then the pressure over the cornea. These things are there, but most of the times, like on the normal cases, we don't have problem. In high myopes and low, in those cases, you do get. So in that, it is always better to correlate with your refractive corrections.
Yes.
And
thank you.
We all, most of us.
Thank you so much.
Yeah, thank you.
Yes, you were saying something.
No, this is the basic things, and most of us are not doing. We are training our optometrists to do that. That is also one thing. So
yes, because most often it is our optometrists who are doing the scan, so they need to know about these
because
things,
Ellen wanted
and
me to speak
especially
about
when
basics.
and when there is a difference between the two eyes. That also is something that they need to come to us with.
Definitely.
Yeah.
Thank you.
Thank you so much, sir. Now we move on to our next speaker, Dr. Anurag Mishra. He is a cataract and refractive surgeon, a very prolific, very promising surgeon from Radha Raman Netralaya, Bhubaneswar. I have heard some of his talks. He is a very good teacher, I can say. Dr. Anurag Mishra, we would like you to give your talk, please. Do you have a recorded one, or are you going to present here?
I did upload the recorded version, ma'am. Request the admin to create.
Greetings and regards from the land of Lord Jagannath. Thank you so much, organizers, for the opportunity as we take a deep plunge into the world of biometry and decide which biometry to opt for, practitioner and practice specific. Before anything, there's a small disclaimer that I do work with the industry, but none of them has got any bias on me as far as this particular talk is concerned. So before we go to the technological frontiers, let's decide what are the desirable outputs that we desire from any biometry machine. These are the two, keratometry and axiometry, because these are the two variables that are used by all the Iol calculation formulae that have ever evolved. However, there are certain emphatic value additions that some of the biometries offer us nowadays, like the corneal thickness, the ACD, AQD, the lens thickness, and the white to white. These four variables are utilized in the modern day calculation formulae. There are certain bold facets which were unexplored until recently, like the topography, if it can be incorporated into the optical biometry, the posterior corneal curvature, the angles, alpha and kappa, the higher order aberrations, MTF curve, residual refraction predictability at the spectacle plane, and the ray traced and AI-based Iol calculation formulae, which are going to be the future, whether or not they can be incorporated into the biometry machine as well. Ideally, we would want all that under one machine, but at the moment, it seems a little far-fetched as a thought. We have to invest a lot to get all of these into an armamentarium. To me, the boldest facet, which has not been explored to the fullest until recent biometry machines came to the market, is reliability indicators. We have to know how reliable are the readings that we have taken. Right. Now let's take a dive into the technological frontiers. The first concept that came was based on partial coherence interferometry technology. It used the light source of 780 nanometers multimedia light display with two mirrors, one of them moving, the other one is fixed. Both of them had light rays going into the eye, and a photodetector device got both the waves coming from the fixed and the moving mirror. When the moving mirror is adjusted such that both of these waves come to phase with each other, they produce a constructive interference. The machine gave us very good readings regarding axial length, regarding keratometry, regarding white to white, but the anterior chamber depth was a slit beam reflectometry technology and not an actual measurement, and it also did not give us lens thickness. The next technology came in, which was optical low coherence platform, optical low coherence reflectometry. Here in the design was of a single mirror, but the light source had 830 nanometers of wavelength. The wave that got reflected from the eye was caught by a photodetector device, and it also had a population derived graph already fitted in the machine. Both of the waves went for a Fourier transformation to give us a continuous A-scan curve. Once you get a continuous A-scan curve, you can measure the distance between any 2 points, and it also gives you the whole axial length and the whole keratometry derived from more number of points. However, this prototype machine did not have good functionality when it came to penetration, although theoretically the wavelength was higher. The penetration was suboptimal, and the reliability index in this machine was the A-scan curve. However, the A-scan curve was a minimalistic one. It did not have details. Next came the present-day technology of step source OCD. The step source technology is a narrow beam of light and not a single ray. The beam of light has a broad spectrum of wavelength ranging from 1030 to 1080, talking about the prototype machine, the median being 1050. It also employed a single mirror design, and the light ray coming in was being reflected into the eye and being caught by the photodetector device. This machine, the prototype machine, scanned the eye into six different radial meridians along 0, 30, 60, 90, 120, and 150 degrees. Each meridian was scanned 5 times to give us 2000 scans per second, and it gave us a continuous B-scan picture wherein we can calculate any point to any point in terms of millimeters. It also gave us AQD, lens thickness, and central corneal thickness, and it also gave us clues regarding lens tilt whenever it is present. By looking at the actual placement of the lens in the B-scan, we can know that. Apart from this single B-scan picture, it also gave us the foveal pit from where the ray has been reflected to let us know whether the ray has reflected from the proper area or not. So that gave us a fixation check, the central 1 millimeter scan, and repeated 3 times. It also identifies macular pathologies at times, like, for example, in this case, where the optometrist brought my attention to this happening in the macula. We did an OCT and found out that there's actually an ERM pulling along and producing macular edema. So this was just one example of the many that we have. Out of these three technologies and the modern day machines, let's look at the reliability indicators. Where are they? The modern day machines have these keratometry printouts where if the Myers have not been properly taken, the machine cross marks them. You can also look at the Myers yourself on the cornea to see whether the reflection has been proper or not, to know whether it's reliable. The axiometry readings have to have within 20 microns. Between two subsequent readings, the difference has to be within 20 microns. And the keratometry readings also has to be within 0.05 millimeter for that to be acceptable. If it's not acceptable and not falling in that range, then you can discard the reading and take it again. And we just discussed about the foveal pit being visible clearly. If it's not visible, you can discard the reading. These are all possible in the modern day step source technology machines. The earlier machines just had the standard deviation as the only reliability indicator. This is one other modern day machine which also utilizes ray tracing technology along with step source OCT, where a host of acquisition quality has been represented. And you can see fourth from top, the tear film and the lid integrity are also shown by the machine. It does not calculate or show the tear film integrity to you, but if the machine does not find it trustworthy, it will always give you a signal whether it's acceptable or not. The bold facets, these machines do not calculate axial length, do not calculate keratometry. They give us certain unexplored areas like the higher order aberrations, the angle alpha, angle kappa, the refraction at the pupillary plane. So they let us plan for advanced technology IOLs and certain refractive procedures. This is another machine which calculates keratometry, though no axiometry, but interestingly, this gives you a green banner down below here, which gives you the spherical and the cylindrical values along with axis at this spectacle plane, so that you can modify your result by modifying the size of the incision or the location of the incision. So this is the machine that we just talked about a while back, which gives you a complete printout like this, the wavefront analysis of the cornea, the B-scan picture, and a host of values along with the x-axis and y-axis displacement of the center of the optical axis and the center of the limbus. It gives us an A-scan which is fragmented between the cornea and the retina. However, it is a very detailed A-scan. It also identifies macular pathologies or vitreous pathologies by showing you spikes over there. The machine also has an excellent anterior segment OCT. This is, as you can see, a phakic IOL, and you can also calculate the wall distance from different points. So after discussing all the technological frontiers in a nutshell, I'm sorry I could not be more detailed than this due to the constraint of time. Let's talk about the verdict. So when you are deciding on a machine, neither pure science nor pure finance can be the sole factor which can take a call. So you have to bring in a balance. If you do not have strong hold on your finances right now, you can compromise with science, but not for too long. If you are a startup, any partial coherence interferometry technology machine will do, and those machines perform very, very well, nothing to discount. But an upgradation should always sit in your mind. And the upgradation should be upgradation in biometry, to me, should be the first upgrade that a startup should be looking at. So whenever you have the strength to upgrade, even before you upgrade your phaco machine, you should look forward to upgrade your biometry. So, and the other thing that comes from me as a personal piece of advice is, if upgradation is available with the same manufacturer from where you have taken the basic machine, it's all the way better, because the buyback and the deals would be that much more easy to do. So ultimately, the step source OCT machines are the way to go if you are a little interested in giving your patients precision outcome. However, you can start from a scratch and then build up on your practice. Just as you have built up on your practice, you can build up on your infrastructure as well. With that, I remain. Thank you so much once again for the lovely opportunity. I really enjoyed this one. Thank you.
Thank you so much, Dr. Anurag. It was a wonderful presentation, and definitely swept source OCT is the way to go. But for our viewers, I would like to ask you, what about eye tracing technology? Because nowadays a lot is being talked about eye tracing being the way to go. So what are your insights into it?
One of the instruments that I just showcased that comes from the House of Heidelberg Engineering, they have come up with this recent biometry, which also has ray tracing incorporated along with the sub-source OCT technology. However, they do not show us the detailed corneal profile the way an eye trace shows. At the moment, they have not upgraded the machine to that level, but they are working on it. That's what I've heard. Eye trace is a wonderful equipment, but it's, as I said, it's a value addition. It's an ornament which actually decorates your investigation area. If you can afford it at any stage of your practice, you should go about it, because the things that I did not put an emphasis on due to the interest of time, there are a lot of things the eye trace shows. It does not show you the axiometry though, apart from the higher order aberrations and the angles that we often talk about. It also shows us the modulation transfer function curve, which is a very, very important thing when you're trying trifocals, because it shows you whether the patient has reduced contrast sensitivity already pre-existing. So in those cases, you have to be extremely careful while trying the IOLs that reduce contrast sensitivity even further. Apart from that, it also shows you the dysfunctional lens syndrome, the so-called Zernike cataract. When you suddenly have a patient who has got everything right, the vision's improving to 6/6, but the patient has difficult night driving. So when you investigate, you find out that under myopic pupil conditions, the patient has a dysfunctional lens syndrome and the image is not very clear. So eye trace is, if you're talking about the eye trace based IOL calculation formulae like the Olson's or the Oculix, well, the Oculix is incorporated in Heidelberg's Anterion. I have worked with it, but I would say that at the moment, it does not appear to me to be a full-fledged or a finished product. They have to work on that to improve its accountability, because at the moment, it just tends to shift the patient's outcome towards myopia. And it also is a little over-inclined towards selecting toric IOLs for patients who do not otherwise require it. So I think ray trace based IOL formulae have to come with a little bit of artificial intelligence to give us that precision in outcome. At the moment, they really, just by a short margin, fall short of it. But as far as machines with ray tracing technology is concerned, they're an absolute must if you want to upgrade yourself to the next level. However, one has to afford it because they are expensive.
Yes. So the Heidelberg is a combination of both?
It's a combination of both. It gives you everything virtually in the anterior segment, right from axio, keratosis to topography, anterior segment OCT, and a little bit of wavefront analysis, out of which the wavefront analysis is the weakest part of the machine at the moment, but I'm certain that they'll improve it in the future. But yes, it's a comprehensive machine for sure, but it is also the most expensive biometer you have in the market.
Yes, that is true. Well, if there is technology there, it does come with a cost. So it's like you said, it depends at what level of practice you are in, how you reiterated that having a good biometer, you should first invest in the biometer and then in the phaco machine, which is so right, because today cataract surgery is basically a refractive surgery. So it would come with a cost, but giving the proper results is so very important. Thank you so much, Doctor.
Before we close this segment, I would be delighted if Ramesh sir can chip in. I can see him in the panel. So if he could, chip in with his comment. I'm very eagerly waiting for your comments, sir.
Yes, definitely. Dr. Ramesh, we are looking forward to you.
Thank you. But I have not used the Anterion or the eye trace for biometry purposes. I've just seen the printouts and some of the data which they give. So I actually can't contribute to this.
No, I was actually interested to know what's your inputs about the upgradation. I mean, you start from basics and then upgrade. Did that seem to be the right idea to you?
Yeah. Yes. So that's an extremely valid point. I think we should get a very good biometry in place and not spend time on a better phaco machine, which is not needed. Yes, I agree with you totally on that.
Thank you, sir.
That's a wonderful message that both of you have given us. Thank you so much, Dr. Anurag. And now I would invite Dr. Ramesh Dorairajan to, of course, he needs no introduction. And He's going to talk on IOL formulae, when to choose, how to calculate, personalize your A constant and surgeon factor.
Thank you, Dr. Shilpa. Shall I proceed? It will be a live presentation. Okay. So we all know
Yes.
that patients' happiness depends on getting 20/20 at least in one eye. And this depends on a series of factors, not only on the formula that we choose. It does depend on the biometry. There are
So
also
if you could go to the slide view, because slideshow, yeah.
Doctor, you
can
can play
see it now,
presentation
or
mode.
you're not able to see it?
Yeah, we can see it. Yeah.
You're happy? Okay. So there are important surgeon and lens related factors too, which we generally tend to ignore. So let us just go through them. So it's important that we make a temporal incision and not make an incision wherever we like. And the most important thing is we must have an rhexis which overlaps the lens. The one single surgical maneuver that you can make to improve your outcome is to have rhexis overlap. If your rhexis is large and the lens is able to pop out of the bag, then your postoperative results will be all over the place. You won't have a tight result. Also, we should use single piece lenses of planar design. So majority of us are using axial length based formula selection, and we know what this is. For short eyes we use Optical. For the normal eyes, average eye we use SRK2, SRKT, Holiday, and for the long eyes we use SRKT. This is what we have been doing for several decades, and this was the state of art till about 2010. So do we have a perfect formula? Till recently, there was no perfect formula, but today we have strong guidelines. The United Kingdom national guideline is for ultrasound biometry and manual keratometry. They have a set of guidelines. And for optical biometry, they suggest a more advanced and a recent formula. So this is the quality standard statement, which was published in March 2018. And this is the current guideline of the Royal College of Surgeons. Less than 22 millimeters axial length, you please use Heges, which is optimized, or Optical. Between 22 and 26, use Barrett's Universal 2 or SRKT. And if you have a long eye, please use SRKT or optimized Heges. Now, what is optimized Heges and unoptimized Heges? Many of the biometers and ultrasound machines have a Heges formula. If you use optimized Heges and these guidelines, 50 to 80% of your patients should be within 0.5 diopter error. So how do you know whether you're using unoptimized or optimized Heges? Without optimization, the A1, A2 constants will have a fixed value of 0.4 and 0.1 for all lenses. So here an example of a printout with an unoptimized Heges for this particular lens. A1 constant is 0.4. If it is optimized, it will have a 0. triple digit number. There will be 3 digits beyond the 0. Why do we need various formulas for different eyes? Jack Holiday, about a decade ago, taught us that there are 9 types of eyes. Most of us are dealing with the average normal eye where any formula will work, but we do get very large or small eyes as well as very short or long eyes. And for these unusual eyes, we need to use unusual formulas with more points of data. Biometry is a moving target and the information base is moving. So please visit Warren Hill's site. We all know it is drhill.com. Every year he updates the site and we tend to learn something new. So what is the ideal formula for optical biometry users? Till recently, the best option that we had was the Barrett suite of formulas, a group of formula which is present in the APSCRS site. This Barrett's online ASCRS and APSCRS online versions are different from what we have in our Lens Star and in our Iol Master. We tend to have the older versions with us. In 2017, we had a large outcome analysis of 13,301 patients. One of the co-authors is Jack Holiday. So this gained a lot of respect in the community. And Ronald Millis was the first author. And their conclusion was, overall, of the various formula that were studied, Barrett's Universal 2 had the lowest prediction error for the Alcon series of lenses which were studied in that particular series. So Barrett's Universal 2 was accepted as the best formula to be used by the year 2017, and everybody started using it. The following are some of the slides from that particular presentation. Here we see that as the axial length varies in the shorter eyes and in the long and in the shorter eyes and in the longer eyes, the variation from the zero value tends to go up. So this is a total zero error for the normally used eye between plus 18 and plus 24. When you're using an intraocular power of between 18 and 23 or 24, most formulas will give you excellent results. But when you have extremes, the myopes and the hyperopes, most formulas don't do well. So the question now is, which formula works well across the entire range? If you take a 0.25 plus or minus error, you'll find that you have 4 or 5 formulas which tend to do well. So it's not that Holiday 2 is bad or Olsen is bad, but among them, Barrett's Universal 2 is slightly better. And for the toric calculator, it is useful if you use 3 different sources of data for the K1, K2, 2 biometers and 1 topographer. In 2019, 2 years ago, the same author, Ronald Mellis and co-authors, reassessed a different formula, and they came to the conclusion that KM formula is more accurate than the Barrett's formula. This was reiterated a year later because the Jan to 2020 in JCRS also, they went through somewhere about 10,000 odd eyes from the UK National Health Service post-op patients, and their conclusion was overall for each axial lens subgroup, this single KM formula is the best formula that we have today. It's a free online formula. It's like a black box behind. We just see this front screen. We have no idea how this formula works. And it is applicable only for these 3 group of patients: the regular patients, toric lens patients, and keratoconus patients. They don't have a post-LASIK formula as of now. So for the last 6 months or so, I am comparing the Kane printout and the Barrett for all my toric lenses. For majority of the patients, they both will give you the same kind of lens and the same kind of axis. On the left, you have the Kane. On the right, you have the Barrett printout. So this says 176. That also says 176. In a few of them, about 5% will have the small 1 or 2 degree differences, 178, 177. 1 in 20 or 1 in 30 will give you a huge difference. Like in this patient, Barrett's, the one I normally use says 126 axis, and here it says 118 for the same patient. So once in a while, you do get this large differences. As of now, I'm not sure which is better for Indian eyes, and I'm using the average when the difference is more than 3 degrees. Kane keratoconus formula is currently the best formula with significantly lower MAE, mean error, compared to all the remaining formulas in patients with keratoconus. For unusual patients who need to have a lens exchange done, or if you want to put a piggyback lens, then you have to use a Barrett's RX formula. So Barrett's RX formula, the outcome analysis formula, can also be used in toric lens patients where you have to rotate the toric lens to a different axis. So in summary, careful measurements are very important. If, like most of us, you are using an ultrasound biometry, please use the Royal College advice based on the axial length. You can choose to use Kane or the Barrett's formula if you're using optical biometry. To improve your outcomes further, you have to personalize your A constant. So what is optimize A constant and a personalized A constant? Optimize A constant is free online, available for all optical biometry users, because instrument-to-instrument variation is minimal, while instrument-to-instrument keratometer, manual keratometer, and manual A-scan machines have their own issues. So we had to personalize the data. So take 20 patients, use the same biometer and the same keratometer, and conduct the pre-op and the post-op measurement. Post-op measurement should be done 2 months after surgery. Use the same technique and the same lens. You have to exclude the cases which had intraoperative complications and which had visual acuity of less than 6/9. So once you have this group of this data, pre and post-op, you must see whether the outcome, the mean of this is 0. If it is not at 0, the mean error is not 0, you have to personalize your A. A constant. So personalization is shifting this error back to 0. In this particular patient, you can see there's a small hyperopic error. So this error has to be, you have to increase A constant and put a slightly stronger lens in your particular group of patients. Now, when you personalize, it will vary from site to site. So if you're a surgeon who does surgery in 2 different hospitals, your personalized A constant will vary from one hospital to the other because the instruments will be different. Jack Holiday consults for a number of large practices, and he says that in his estimate, less than 25% of doctors personalize their A constant. For the average surgeon who doesn't personalize the A constant, 50% of cases will be more than half a diopter off. After you personalize your A constant, you have to find out what your surgically induced astigmatism is. This you can do from Warren Hill site. And this was done by me about 4 or 5 years ago. So here you have the pre-op K1, K2. You have the post-op K1, K2. And you have the change in axis. And once you have the data, you'll find that in this series of patients, my SAA varies from 0.61 to 0.06. So you'll find when you do this that your SAA is for the right eye is different from the SAA in the left eye. SAA is also different depending on where you make the incision. The temporal incision SAA tend to be the lowest, while the oblique and superior incision SAA tend to be lots higher. So all of us should move towards making temporal incisions, and all of us should go through this exercise with our data. We'll tend to learn a lot from this. Here's an example of a patient with an axial length of 30.47 millimeter. So we used SRKT in this particular patient, and post-op result was this patient has 6.9 plus, and he accepted a 0.25 to reach 6.6. So getting a reasonably good result in these eyes is quite possible if you're using a current technique and current technology and current formula. Thank you. With this, I'll close my presentation. And if you have any questions, I'm ready.
I have one question, sir, for you. You make always temporal incision. So yes. Is temporal incision is better, or with keratometry based incision is better if you are not using a total lens?
So I strongly believe that that I should always make an incision on the steep axis. Till recently, 4 years ago, when I calculated my own SAA, I found that if the eye is oval and the pupil is nasal. So if you make the incision far away from the visual axis or the center of the pupil, you will tend to have the least amount of effect. So you can be far away from the pupil only if you are making a temporal incision. So I no longer make oblique or steep axis incisions, always temporal.
As it is, sir, after the centroid concept has come in, now we know that since we are all shifting to the 2.2 to 2.4, talking about the size of the incision, we know that the centroid concept has revealed that with the 2.2 to 2.4, the surgical induced astigmatism, wherever you place it, is around 0.1. So it hardly makes a difference. So on-axis surgery is something even I used to follow a lot, but not anymore because of this. So it's actually come out to be true that the induced astigmatism with the 2.2 to 2.4 is, if you're going to beyond 2.4 though, Dr. Koch is largely silent on that. So maybe on-axis planning can be done, but within this range, you don't need to shift to the steep axis necessarily.
Also, the second issue is now, even though you make very good incision and do a proper surgery, many will be fine. They'll have a very small or close to 0 SAA. Once in a while, you'll get a 0.3 or 0.4. It won't be on that axis. It can be like 30 degrees away.
True.
We imagine that only that area is going to flatten and we're going to affect the steep axis. It doesn't happen like that. It can affect 40 degrees away, 12 degrees away. It can be the effect can be the axis on which it acts can be on the right or the left side. So it's not that simple. It's not that predictable. It's easier to make all the instances temporal.
maybe one of the contributing factors to this, sir, would be the fact that what we think as 20 might not be 20. If you do not have an image guided system to guide you where 20 degrees axis is precisely, you might just land up at 30 and think it to be 20. So the whole game, the whole vector point changes then. So yeah, it's a good idea to stick to temporal, as sir said.
That's a nice presentation from sir, and we always appreciated Ramesh sir. Our next speaker is Dr. Shilpa. She is from Belgaum and she is an excellent cataract and refractive surgeon. She will be talking on IOL calculation in post-refractive surgeries. And we have been seeing her speaking in a lot of conferences, and she's really excellent. So we'll enjoy her talk now.
Thank you so much, Dr. Mohammed, for this introduction. I have my recorded video. I'm Dr. Shilpa Kodkani from Belgaum, and I thank Dr. Ellen Kumar and the organizers of COSCON 2021 for giving me this opportunity to talk about IOL power calculations in post-refractive cases. Let me share the screen. In routine cataract surgeries, the current standard IOL formulae are the third or the fourth generation formulae, which are basically theoretical formula like the Hoffer Q, SRKT, Holiday 2, and nowadays, of course, the Barrett Universal and the Hill RBF formulae. Usually, we use Hoffer Q for short eyes, SRKT for normal eyes, and Holiday 1 for long eyes. And the newer generation formulae, like the fourth and fifth generation, are formulae which can be used for all eyes. They all go by the Virgin's formulae, which are basically dependent on Gaussian optics. And it was Figueroa in 1967 who invented these formulae and which are being used even today. But the primary goal and actually even the weakness of these formulae is the estimation of an accurate effective lens position. And that is why more and more variables have come in to be able to give us a more accurate ELP. Now, in an effort of pursuing perfection in intraocular lens calculations, the nomenclature for classification of these formulae has changed from the earlier generations that we used to use to now what we use as the number of variables, like 2 variable formulae, 3 variable, and like in the Barrett Universal 2, you have 5 variables, which is apart from the keratometry and the axial length, it also takes into consideration the anterior chamber depth, the lens thickness, and the white to white. So because of these variables which are being added to the formulae, they give more accuracy in estimation of the ELP. These formulae use corneal power in 2 ways. One, the corneal power is directly used in the Virgin's calculations to predict the post-operative diffraction, and 2 is the prediction of the ELP, which is basically the depth of the IOL relative to the cornea. And it is assumed in most of these formulae that the AC depth is 4.5 millimeters, or the ELP would be 4.5 millimeters, and this would be standard over all eyes. And this is where the scope for an error. So that's why newer formulae. Now in the standard keratometry, it measures the anterior corneal surface. The posterior corneal surface is usually extrapolated, and the normal anterior posterior ratio is assumed to be 0.8, which works very, very well in virgin eyes. But following a refractive surgery, it introduces an error in the measurement of corneal power and also the prediction of the ELP. This is because now suppose you have a patient with a refractive correction done. If the keratometry earlier pre-LASIK was 42 and now it is 39, the regular powers, like say the SRKT or the Hoffer Q, would assume that because the corneal power is less, the anterior chamber depth also would be equally less and would give you a power which would be lower than what is estimated. So it would underestimate an IOL power in a myopic LVC, whereas an overestimation of IOL power would happen in a hyperopic LVC. So this effect on the ELP is because when the corneal power is altered, the depth of the IOL will remain the same. And that is why after a myopic LVC, the corneal power decreases because the ELP estimates become too low. So in post LVC, the anterior corneal curvature is altered, the posterior curvature remains unchanged, and the normal anterior posterior curvature ratio is also altered. And as you can see here, there is a wide optical zone because of which this ratio of 0.8 is no longer valid. So in post LVC cases, for getting a good keratometry, you need to measure the anterior corneal curvature, measure the posterior corneal curvature, obtain the net corneal power to be able to get a more accurate IOL power calculation. And for this, there are different methods which are available. Like for example, if you have a pre-LASIK data, a double K method, that means now, for example, if you have calculated on an SRKT formula and you know that a myopic correction has been done of say -8, and now you have an axial length measurement of 26. It means that from the IOL power calculation on an SRKT formula, if you get say 20, you need to add 2.6 to this calculation, and that will be the accurate ELP and the accurate IOL power. So in myopic correction, you need to add, and in a hyperopic correction, you need to subtract. The other way of doing it is obtaining the corneal true K by various methods of adjustments, and of course the different formulae that can be used, and we can input the true K into these formulae. And the formulae, like for example these Sharma's formula or the Koch and Wong formulae, they take into consideration the calculated corneal power would be the post-LASIK corneal topography central K along with some constant which would give you the calculated corneal power. So this is how in post-LVC cases, it is the corneal power which needs to be very accurately determined. And now you have different formulae like on the websites. If you go on to the ASCRS website, you could put in the pre-LASIK data if you have. Here I have entered a pre-LASIK data. I have put in the biometry readings, and you would get a result like this, where an average of all the formulae which could be used depending on the variables that we have put would come to, in this case, 22.95. Now, if you put the same parameters into the Barrett 2K universal formulae, wherein you have a pre-LASIK data available, you would get again a 22. So if you go back and you see that the Barrett 2K with the previous data available would be around 22. So this is how it calculates. Without pre-LASIK data, the same data being put, but without any pre-LASIK data, you would get 23 on the Barrett formula. Now it is this same patient where we have used the Heges L formulae, and this is how you get 24 diopters. So from 22, it has gone to 24. In Holiday 2, it is giving you 21.5. So it's all erroneous with the regular formulas that you would use. So it is important to use the websites on which you get a proper IOL calculation. You can also do a pentacam analysis or a cirrus analysis to see, and you can see the EKR in these post LVC cases will show this kind of a reading. So points to remember in post LVC cases is that standard keratometry is not going to work. Online calculators are going to give you better predictability, but about 70 to 75% in no pre-LASIK data. The predictability would increase by 5 to 10% if pre-LASIK data is available. So when we do LVC, it is important to educate our patients to keep their pre-LASIK data, like your corneal topography, all the reports have to be kept with them so that in the future, these can be utilized. Of course, topography would help, and an OCT to obtain the net corneal power, very, very important. Predictability from 80% can increase to about 90 to 95% with better technologies which are available today. However, with all these things put into place and newer formula and the ability to get the true K and the net corneal power, it is still important to spend some chair time with our patients with LVC who require, with a cataract who require an IOL into their eyes, that these patients are counseled that there is a possibility of some kind of an error which can occur, but we have to aim at minimizing these errors. And we also need to remember that such cases over a period of time are bound to increase, because we have been doing LVCs for patients at the age of 20, 30, and almost 20, 30 years back. So now they would be coming for their cataract surgeries. So post LVC cases with cataracts are bound to be on the rise. Thank you very much for giving me this opportunity.
Can you play the last video? We'll finish it with that, please. Sorry for the trouble, Dr. Mohammed Shahbaz and Dr. Silpa Kodkani.
No, not at all. The next topic is post-operative refractive surgeries. What are the surprises? What are the options? When do I intervene? How do I do it? Dr. Vinod Arora.
Can we?
Cataract and refractive surgeon, Navjyoti Eye Hospital, Dehradun.
Dr. Shilpa.
Good afternoon.
We are actually running short for the oration. Can we have Sir's video later? Sir's and Dr. Subramaniam's later after the oration. Can we please?
Okay.
Okay, we'll have this because next is also a cataract session. Okay.
All right.
Okay. Please stay on the line. You can just mute it.
So we have Dr. Vinod Arora with us.
Yes, sir will join. He told me to play the video. That's right. He has another talk in UP conference actually.
All right. So we have Dr. Vinod Arora, who is from Uttarakhand. He's a cataract and refractive surgeon from Navjyoti Eye Hospital, Dehradun. And he will talk to us about post-op refractive surprises. What are the options and when?
Good afternoon. I'm going to speak on refractive surprises following cataract surgery. Let me share my presentation. So cataract surgery has now become a refractive surgery. Patient wants the very best. They want to have very good vision. They want to read 6x6, see 6x6. So are we ready for this challenge? Let us see. And in spite of all the best things, refractive surprises do happen. So how to manage these cases? It's again very, very important. So what is refractive surprise? A surprise, there is a significant difference between the post-operative refraction and the pre-operative planned result. So we got a lot of difference. That means it's a refractive surprise. What may be the refractive reason for this refractive surprise? As we know, all the instruments have some limitation of precision and accuracy of biometric measurements. Then we know the Iol where it's going to be placed is not very sure. That is effective lens position. So it may be on the back of bag, it may be in the middle, it may be on the front. So we are not very sure about that. And measuring wrong causes a lot of problem also. If there is a measuring of error of 1 millimeter in corneal radius, that may cause surprise up to 5.7 diopter. If you feed 1 millimeter of axial length wrong, it causes 2.75 diopter of surprise. Then AC depth 1 millimeter can cause 1.5 diopter of surprise. Iol power, if wrongly fed, is 1 diopter, it can cause 0.67 diopter of surprise. So these are the various Iol formulas which has been discussed in previous talks. Is on axial length based. Then we have in special situations. These are specific conditions like nanophthalmos, then post-refractive surprises. So we have to use various formulas. I'll not go into details because it has been already covered. These are the newer formulas, which are very, very accurate, can be used in most of the conditions and available online also. So this is how we have SRS calculator. We can just calculate what is for myopic, for hyperopic eye, prior RKI, where we can get an accurate reading. So what are the risk patients? Small hyperopic eyes, large myopic eyes, which have a big bag, then very steep or flat case, then shallow anterior chamber depth. If there is a prior history of refractive surgery, or if the keratoplasty has been done earlier, then vitrectomized eye, or if there is a previous surgery of refractive surgery like LASIK or RK. These are going to be a big chunk of patient coming future. So we have to be already ready for that condition. Corneal ectasia may be there, or contact lens, we have to give a sufficient time to avoid dwarfage. For soft contact lens, I give 1 week. For GP lenses, avoid at least 1 month prior to surgery or taking any reading for these patients. So suppose you have done everything well, still the patient has surprises. So what to do? Our first thing is we should go on a backward way. We should see whether the patient was right or wrong. In a long queue, it can happen. Then the patient eye was proper or not. It was the right eye or we did on the left eye. So if the patient has cataract in both eyes, our calculation for 1 eye, and patient decided to go for second eye. Third, whether we have used a proper Iol or not. Sometime in inventory with the proper Iol like techniques may not be there. And our staff has given the Hoya for same power. So it can cause surprises to us. Then coming to the condition like phimosis, which can cause anterior shifting of the lens, causes myopic shift. We can just give a small nip with YAG laser and it can solve the problem. Now coming to the real reason, how we can manage these surprises. Suppose it has happened. So now what to do? First thing is very important is give spectacles. If patient is happy with the spectacles, don't do anything. Don't try to be heroic. Contact lens may not be very good choice in an elderly patient. Then corneal surgery like LRI, very good. Laser vision correction can be done. Then Iol exchange or rotation of the toric Iol can be done. Then piggyback Iol implantation like Iol or ICL can be done. So mini RK is very good thing. It can reduce the amount of myopia. Of course, it's not very precise, but very economical. And there may be glare in some of the patients. LRI, again, is a very, very good choice. And it should be practiced by most of us, or rather all of us. It gives a very good correction in hyperopic astigmatism. It can take care of the hyperopia plus astigmatism part also. But can be used to reduce in mixed astigmatism also. These are the calculators available online, and we can feed the data and know how much the arc is required, how much is the axis where we have to put it. And these are all there in a graphic form. We can just utilize it to reduce the amount of cylindrical number. Then laser vision correction is probably one of the best choice in majority of the cases. The advantages are obvious. It avoids intraocular surgery. There is a quick recovery. It can correct any residual error. But the disadvantages are it induces higher order aberrations. It can cause dry eye, which are very common in elderly patients, and it's irreversible. It may not be available to all ophthalmologists. The tips, if you have a risk patients where you expect they're going to be surprised, so you can make a pre-surgery flap. The tip here is do not lift it. Either you're using a microkeratome or if you're using a femto, leave it there. Just make a flap and leave it there. If you're making flap post-surgery, then wait for refraction to stabilize. It should be minimum 1 month after phaco and 3 months after small incision cataract surgery. When the refraction is totally stabilized, then go for LASIK procedure. Femto is preferred in these cases. Advanced surface ablation is again a very good choice in small errors. We should do transepithelial PRK in these cases. And dry eye is more common in elderly patients. So we have to use a lot of lubricants in these cases. We should not use mitomycin as the cornea is already very stiff. Iol exchange is good, but my least choice, use plenty of viscoelastic, disengage the haptics from the capsular bag, use a good cutting instrument, don't fumble with the inferior quality of instruments. If you find any difficulty, it's better to increase the incision than struggling inside. So what are the tips? Avoid as far as possible. Verify the problems. If required, do it earlier, preferably 1 to 2 months. And you have to use plenty of viscoelastic. We know it's difficult to remove IOL in some cases, may cause trauma to rex's bag or surrounding structure. Astigmatism may be there, which can be induced by stretching too much or increasing the incision. The result may not be perfect sometime. In spite of putting second lens, you may be in problem again. So other choice is putting an ICL, IPCL. It's can correct almost most of the conditions. It retains the corneal sphericity. There's no regression, but it's quite expensive at present, and long-term effects are not known. Then coming to the piggyback lenses, like hyperopia is a better outcome than laser vision correction, and these are reimbursable. Insurance covers it. Then coming to the complications of piggyback IOLs like interlenticular membrane, pseudoexfoliation, pigment dispersion, corneal endothelial decomposition. Of course, these are not common with modern lenses like Sulcoflex. It's a quite good lens and comes in a size of 14 millimeter. We have got a variety of multifocal or trifocals in these lenses. We have toric lenses also and multifocal torics also. It can be used in normal patients who has gone for monofocal and you want to have a multifocal, you can put a plano multifocal there also. It can be used with toric also for plain toric correction also. So this is the surgical procedure, nothing much specific. Put a visco, slide, put the lens like what you do normal foldable lenses and slide into under the sulcus, in the sulcus rather. And calculation is very, very simple based on the refraction only. Myopic correction, if there is a spectacle power is of 1 diopter, you have to use the same power. Suppose your surprise is -2, you have to use -2 diopter lens. For hyperopic correction, we have to multiply by 1.5 diopter. For a +2 surprise, we have to use 3 diopter of correction. This is the same technique. I'll not go in detail. These are the other type of lenses available. These are called add-on lenses. Then Sulcoflex, it's from Indian company. Again, very good lens. The advantages are it's safe, reversible, it causes less trauma than IOL exchange, and it's biocompatible additive implant. Opening of the bag is not required. Post-operative refraction is very high predictable and simple calculation. It's a reversible. You can easily take it out if anything goes wrong. And specific indication, you can use it also to treat dysphotopsia. The flip side is that there's a new concept. There's a lack of peer review publication. Of course, we got no good number of publication too. Then stability may not be very, very high, especially in toric cases. So just to conclude, there's a variety of options. We can go for IOL exchange. We can go for LASIK vision correction. We can go piggyback IOLs. We can have myopia For myopia, LASIK vision is much preferred. For hypermetropia, piggyback or IOL exchange are preferred. For astigmatism, we can choose piggyback, we can use laser vision correction, we can have the LRI. So with this variety of things, we can manage practically all the surprises. Thank you so much.
Thank you so much, sir. That was an excellent presentation, and it has covered all the aspects. If there are any questions from the audience, well, I think we are running short of time. We go to the next speaker now. I now invite Dr. Subramanya Kota. He's a pediatric ophthalmologist and a very prolific pediatric cataract surgeon from Minto Hospital, Bangalore. He will be talking to us on iris fixated IOLs. Over to you, sir.
First of all, I would like to thank KOS and Dr. Elan sir for giving me the opportunity. And mine is very small topic, and I would say it's off topic also, not related to any previous topics. It's just how to use the iris claw lens. Okay. So basically, what I'm discussing here is, am I able to? Is it visible? Hello.
Yes,
No,
doctor, it's visible.
Yeah. So thank you. Here, what I'm going to tell is, I will tell a little bit about the history and then mechanism of iris claw lens, and then I will directly go to the videos. Put only 1 or 2 videos, which I will be explaining you the iris claw lens implantation in steps. First thing about the history. History is little amazing, even though it is started with the worst. That in around 1980, he started the original iris claw lens. Okay, and he observed there was some tissue was got in the slot of his regular iris claw lens, and then he felt like, yeah, the classing of tissue, which made him to think about the possibility of the stable fixation of IOL in the normal regular iris claw lens. Even though it was initially thought by him that all this modified by the Moore and Amar, and then popularization of this technique is observed only recently. And even the few years ago, they were doing the iris claw lens, and many people were not confident. They very used to tell that, yeah, iris claw lens, when you put it, might dislocate into the vitreous, so always go for SFL. This was a thought very long back, and now the trends are little changing. People wants to do iris claw lens, and they were doing very good result with this iris claw lens. Yeah, definitely. Why iris claw lens? When the iris claw lens, it is a very less time consuming and less invasive technique, and it averts anterior chamber angle, but can cause a pupillary block. That's why many of the case where there is a phacolytic glaucoma, where there is a pseudo aspillation with the glaucoma features, it's better to do the pupillary, PA. And there is centration is often, you get a very good centration and a very round pupil if you have done the technique properly. So the A constant which we use is 6.8 for the A scan. If you are doing the IOL master, it's 116.9. Definitely, this is just a photo of my Minto hospital. Definitely, you don't want anybody to wear AFQ glasses. And when you are going for other option, definitely there is SFIL and ACIL. You know, ACL, there are related complications, and SFIL also very invasive technique when compared to iris claw lens. Definitely a good technique, but when compared to iris claw lens, it is a little invasive technique. So this is just a video of advertise of world, like where iris claw, you can see the iris claw lens can be done very fast. This is the particular lens, Artisan Lens, where you can see the big optic, and the aperture between the optic and the haptic part is very big.
No video is Hello? Dr. Subramanya, we cannot see your presentation. We are only seeing a screen, some videos.
Is it visible now?
No.
Now?
Subramanya, exit screen share. Exit screen share.
Yeah.
Okay.
1 minute.
First exit. You are still seeing your screen. First exit ಮಾಡಿ. ಮೇಲ್ಗಡೆ ಇರುತ್ತೆ. Stop screen share. Yeah. Good. Okay. Now open first. ಇದನ್ನ minimize ಮಾಡಿ. Open the video. We have less time, please. Open the video on your screen. Have you opened it?
No. Is it visible now?
No. It will not be visible. Have you opened this thing?
Doctor, video I can play.
You can play the video. Video, ma. Play it. You can talk.
Yeah. Yes.
Subramania.
Continue.
Yeah. Is it visible now? Yeah.
Yes,
I have finished all these things. Should I continue with the same thing or let me directly go to the video?
Go to the next one. No problem. You finished this. Go to the next one.
Oh, Ilan, from there,
Second video. Next video, please. Stop ಮಾಡಿ ಇದನ್ನ.
You can play your video.
Yeah, it's visible actually.
ಇವಾಗ ಓಪನ್ ಮಾಡಿದ್ರಾ ಸೆಕೆಂಡ್ ವಿಡಿಯೋ ಸುಬ್ರಹ್ಮಣ್ಯ?
Somebody was sharing it.
You have to first open. ಅಲ್ಲ video open ಮಾಡಿ. Don't share it. Open the video ಅಷ್ಟೇ.
Video.
After that, you have to go to the screen share.
Yeah, this is the video actually. Is it visible now?
Yes, we
Yeah,
can
it is
see.
visible.
Please, yeah, I will just say whenever I want to pause, please pause it. Yeah, this is Iris class. This is a little bit about the history. Initially, it was invented by Wurst in 1980, and during this time, he observed there was some tissue was caught in the slot of his regular lens, and that was clasping of his iris tissue made him think about the possibility of the stable fixation of Iol. Even though this technique was modified by the this Moore and Amar, but popularization of this technique. Yeah, go ahead. So why iris claw lens? Definitely, when we think about iris claw lens, it's a less time consuming and less invasive technique, and it avoids anterior chamber angle but can cause a pupillary block. That's why whenever just pause it, whenever you doing a iris claw lens for the faculatic glaucoma or pseudo asphyxiation glaucoma, it's always better to do the peripheral iridectomy. And iris claw lens, it's always independent on the AC size, and also centration is good. That depends on the enclavation technique. So if you are done a good enclavation and if you are do good proper technique, and definitely your centration is good and you get definitely good people compared to the other. Yeah, go ahead. Okay, A constant we use is 116.8 for a scan and 116.9 for your optical scan. That is the Iol master. Whenever you definitely don't want a FAK glass to the patients, and also you definitely don't want a costly procedure. Always you want a less invasive procedure when it compares to the SFOL and ICOL. And here it's a very old advertisement show you how to catch the fish just for the entertainment. So you can compare this iris claw lens in this way. It's a very easy procedure compared to the other technique and can be done very fast. Can you just pause it? Yeah. This is the Artisan Lens. Initially they started. You can see the optical diameter is very big, and then aperture between the optic and the haptic is a little more compared to your normal initial iris claw lens. So that's why whenever you are doing the tuck, the centration will be good, and then the stability of the lens is also very good. Continue. And here you can continue. This is how you check the your tensile strength of the haptic. So what they are done, can you pause it? What they are done is they are improved the improved the quality of the lens by some mechanism like a compression molding technology, where they are what they have done is they are by this technology they are improve the tensile strength of the haptic and also flexibility of the haptic. Suppose when you are doing the claw, like even if you are pressed 2 times also, the lens haptic won't break. That is the quality of the newer Iol lens, newer iris claw lens. Yeah. That's how you check the tensile strength of the haptic enclavation. Yeah, this is the have divided the iris claw lens implantation in the few steps. This is the first step where you do a small scleral incision. So here I have done a corneal incision, but scleral incision is a better. It's a slightly posterior to the limbus, and it should be 180-degree apart. So this is the first part of your iris claw implantation. Once you are done, you have to repeat the scleral incision on both sides. Should be 180-degree apart. Yeah. So next step will be the either you can, after doing the anterior vitrectomy, so you can do the surgical PA. Either you can do it at the beginning of the procedure or you can do at the end of the procedure also. But surgical PA is very much recommended in a phacolytic glaucoma or pseudoasphylacean glaucoma where you are done. But it's optional for other cases. And the thorough anterior vitrectomy is the must. You can just pause it. You can do the and once you have done a vitrectomy, yeah, continue. You put the IOL. Continue. What happened?
And that's all, doctor. Only got one video. It stopped.
No, it's there actually. Another few minutes it is there.
No, it's 2.50 minutes. It's over.
No. Can you check it once again? It is there actually. It is continuing for another 3 minutes. There is some.
Okay, you could just say whatever you would like to say about.
Yeah. Once you are done, once you are kept the lens in the anterior chamber, that is usually done with the iris claw lens holding forceps. Whenever you are putting the lens in the anterior chamber, you should not press the posterior lip actually. Suppose if you have pressed the posterior lip, the chance of AC collapse is very high. During this time, you should not panic. You can put the viscoelastic material, OVD. It's always better to put the visco at the peripheral part, that in the center of the pupil, because sometimes it can go into the vitreous and you will have a pupillary block glaucoma. And once you are put it in the AC properly, you have to dial it in the horizontal position where you can enclave it properly. And then once you are dialed in the horizontal position, and then you have to again, you can take either like a visco cannula, or you can take a Sinskey hook or 27 gauge cannula. You can put it through the iris claw lens with the iris claw holding forceps. Okay, and then you drag the iris claw lens towards the posterior part, and then you lift the haptic part so that you can see the prominence of the haptic, and then you have to do enclavation. Okay, so the enclavation should be done at the mid periphery. That is called iris bridge mechanism, where the fixation points always present at the immobile, the virtual immobile part of the iris, that is the mid periphery. So if you have done enclavation, proper enclavation done at the mid periphery, so that even if you want to dilate the pupil or constrict the pupil, like any PRP procedure, any secondary procedure, it is possible, still possible with the iris claw lens. And then you have to repeat the procedure for the other side. And then most of the time with the iris claw, and then you have to wash the whatever visco is there, you have to wash with the normal IA only. And then either you can do the PA at the beginning of the procedure, and even end of the procedure is also fine. Once you are done, definitely you have to suture. If that is also optional for the surgeon. And then I have done quite of iris claw lens, and most of the patients got a very good result. Of course, there are few patients where there is a primary complications or secondary complication can happen, like RD, choroidal detachment is very common with iris claw lens, because you become very hypotonic at the end of the procedure. So those things are common in iris claw SFL also. So with this, I would like to conclude. If any question is there? Hello. Yeah.
I think we have to hand over for the next session. Thank you so much, Dr. Subramania. It was a great presentation, and wish we could see more of your videos though.
Somehow like it is coming here, but it is not coming there. I think.
Yeah.
That is a problem. I guess with
some glitches are always there. Not a problem. Thank you so much, and I thank all the speakers. I thank all the organizers, Dr. Ellen Kumar, for this opportunity, and we hand over for the next session now. Thank you all.
Thank you. Thank you all.
Thank you. Thank you.